Yes.
Okay. Okay, thank you, Kavita, for that very kind introduction. Good evening, friends, and welcome to this talk on revision of radiology cases from the Tumor Board. I'm Dr. Mahesh Kumar. For some of you who do not know me, I was one of the earlier first batch of DNB residents who passed from the institute, and I'm very glad to be back here with the NIMS alumni group and with the Crest Foundation to have this presentation. And thank you very much for organizers for inviting me for this talk. Firstly, I would like to pay my respects to Professor Kakala Subbarao Garu, who has been my teacher and a guiding influence in my career as a radiologist. I have no financial disclosures to this presentation. I would like to acknowledge some of my colleagues at the hospital where I work who have contributed to this presentation, who are also a part of our tumor board and who contributed to the management of these cases. This is the hospital that I work at, City Hospital in Mediclinic, City Hospital in Dubai. To be fair, it has a little bit of a close comparison or a resemblance to our Nizam Institute of Medical Sciences, at least if you want to compare the terracotta color paint on it. The objectives of this talk is going to be to review imaging of cases from the tumor board and to discuss some of the tips and techniques in the evaluation of common lesions of the pancreas specifically, and a few not so common lesions will be included as well. And to also discuss some of the imaging findings and determine management of pancreatic cystic lesions will be one of the objectives. And if we have some more time, we can go through some rare spotters from abdominal imaging. I've tried to divide this talk into three sections, where the first portion of the talk I will speak about some solid tumors of the pancreas, then come to the cystic lesions of the pancreas, and then have some time for discussion on the rest of the abdominal imaging. So moving on to case number 1. Are you able to see clearly? Everybody able to see clearly and hear me clearly?
Yes, Mahesh, just go on.
Thank you. So this is a patient who is a 60-year-old female who presented to the outpatient clinic with loss of weight over 2 months. Patient did not have any localizing signs, was sent for a screening CT. And the set of CT images here on the top row is our coronal post-contrast enhanced images across the body and tail of pancreas. Shows an ill-defined hypodense lesion. There is poor detail of the vessels surrounding the lesion, and the corresponding axial post-contrast enhanced images show a zone of poor enhancement within the body of the pancreas. You can see this is at the distal body and tail of the pancreas. There is some homogeneous enhancement in the head and neck region of the gland, with a sharp demarcation of low density within the body and tail of the pancreas. There is a small segment of the tail seen here with a duct being dilated, suggesting that there is significant obstruction to the duct in this lesion. But are these features in any way specific to make a diagnosis? Probably not, because there are several other conditions which can have this appearance on CT. The CT and MRI are pretty good to detect the lesion, but the specificity is somewhat undermined by the spatial resolution of the lesions, and also the several other lesions having a similar appearance can take down the specificity of the lesions. Now, looking at the lesion on T1 in-phase image, you have a low signal focus within that corresponding lesion seen on CT. The best lesion to identify, the best sequence to identify a lesion in the pancreas is a fat-suppressed T1 weighted image, which shows the rest of the pancreas as a high signal homogeneous structure, and the focus of low signal suggests that there is disease within the pancreas, which alters the signal characteristics of the protein molecules which are present within the acini of the pancreatic gland. The corresponding T2 weighted image shows a intermediate to low signal alteration. So T2 is not really helping to give us any more information about the nature of this lesion. This is clearly a pancreatic adenocarcinoma, and due to the desmoplastic nature of the lesion, you see that the T2 weighted image is of intermediate signal. Diffusion weighted image shows diffuse restriction within the lesion. However, this is again not specific for pancreatic adenocarcinoma because it just signifies diffuse edema within the gland. As we all know that acute pancreatitis or focal acute pancreatitis could have same signal characteristics. Patient then went on to have a MRI with contrast. It shows MRI in pancreatic carcinoma shows a hypovascular signal to normal gland in arterial phase, gradually enhances in the delayed phases. You can see it takes a heterogeneous signal characteristic with a slow enhancement within the lesion. Immediate contrast enhancement phase is probably the most sensitive for detection. The role of pancreatic imaging is to assess resectability of the lesion. Once you identify the lesion and have the diagnosis that this is an adenocarcinoma, the imaging is critical for assessing the resectability of the lesion. Complete surgical resection is the only treatment with long-term survival and possibility of cure for adenocarcinoma. Especially when you see the lesion in the distal body and tail, this is the most dangerous location for these lesions because they continue to grow without producing symptoms. And by the time the patient is presented, they already have liver metastases or spread to the lymph nodes. If the lesion is in the head of the pancreas, they present quite early with obstructive jaundice and other symptoms related to pancreatic dysfunction. The accuracy of CT, MRI, and endoscopic ultrasound are in the confidence interval of 95%. The imaging does well to give good information to the surgeons about planning resectability. Only 20 to 25% of patients are suitable usually for resection, depending on which surgeon and depending on which vessels can be reconstructed by some of the surgeons. I just want to go through briefly the characteristic features of adenocarcinoma for the benefit of some of our residents. The typical appearance of pancreatic ductal adenocarcinoma is because it arises within the pancreatic duct. It first causes a pancreatic ductal obstruction, and therefore you see pancreatic ductal dilatation. In 80% of the tumors of the head of the pancreas, you see pancreatic ductal dilatation, whereas in tumors of the body and pancreas, you see them only in 50%. The classic finding of upstream parenchymal atrophy is present in majority of the tumors. On MRI, the classic appearance is a hypointense mass, best seen on fat-suppressed T1 weighted image and with variable signal intensity on T2 weighted images. Diffusion weighted MRI allows detection of pancreatic mass, and it has a similar sensitivity to that of gadolinium enhanced MRI. Excuse me. The ADC value is low, and of the modalities, which is the best modality? Endoscopic ultrasound reaches a sensitivity rate of 99% if you compare it with 55%, as per a recent study as recent as 2014 by Joanna Gonzalo, published in World Journal of Gastroenterology. Endoscopic ultrasound has a very high negative predictive value, and therefore endoscopic ultrasound can reliably exclude pancreatic cancer. Just want to move this table up here. just coming in the way of my presentation. Okay. Unresectability of pancreatic tumors is one of the most important things that radiologists need to determine for management of pancreatic tumors. Features which are considered as unresectability for pancreatic tumors should be clearly mentioned in the radiology report. These are important points to be included in the report. Infiltration of peripancreatic vessels, celiac artery, superior mesenteric artery, common hepatic artery, proper hepatic, and portal vein and superior mesenteric vein details should be included in the report. If there is invasion of the neural axis around the celiac artery and the SMA, the lesion is rendered unresectable. Invasion of adjacent structures also render it unresectable except duodenum. Also, involvement of the distal splenic artery and vein can be excluded as a reason for unresectability, as most of these patients in the distal body and tail will have a splenectomy anyway. So involvement of the distal splenic artery and vein is not a feature for unresectability. Distant metastases to lymph nodes outside the margin of resection, metastases to liver, omentum, or peritoneal metastases are all features of unresectability. Superior mesenteric vein and portal vein involvement were traditionally unresectable lesions. But some surgeons will now do reconstructive surgery along the venous segments and will resect the venous segments without affecting mobility or reduce survival for the patient. Now, what about metastases from pancreatic adenocarcinoma? Is it easy to identify them? The best sequence is a fat-suppressed T2 weighted image as intermediate or high signal seen in background of fat suppression to identify lymph nodal metastasis has been described. Vargas published a paper to show that liver metastasis was easily detectable on MRI or CT. However, we are still faced with significant problems in identifying false negative small liver metastases, identifying small lymph nodes involved by tumor, and small peritoneal implants. A meta-analysis has shown that the pooled sensitivity for PET study. Is PET in any way better? Probably not. In evaluating end stage and in liver metastases, the sensitivity, specificity, and accuracy was 91, 64, and 67%. So CT PET has no additional value in the diagnosis for pancreatic adenocarcinoma. This is another companion case to show exactly the same features as we saw in case number 1, a diffuse appearance of a pancreatic adenocarcinoma, the only sign being involvement of posterior peripancreatic infiltration into the splenic vessels, a sharp cutoff from the normal pancreas to the lesion. This can be quite difficult to diagnose. The only way is to get an endoscopic ultrasound and to get a biopsy of this lesion. And if it is confirmed, you clearly advise the surgeon of all the other signs of resectability versus unresectability. This patient went on to have a distal pancreatectomy and splenectomy, and CT PET study showing no evidence of residual disease or distant metastatic disease. Case number 2, we have a 40-year-old female with some non-specific upper abdominal pain, came to outpatient clinic and was referred for a CT study. Usually when patients come for a specific pancreatic lesion, we always scan with giving them oral water and intravenous contrast, which gives us better detail of the anatomical structures in the upper abdomen. However, when patient comes with vague symptoms and we are looking for an occult lesion, we usually give them oral contrast, and that is what this patient has had, which shows here that there is a large bulging lesion at the distal body and tail of the pancreas. It has some heterogeneous low-density foci with a definitive high-density capsule-like lesion. The margins are very smooth. There is no obvious peripancreatic infiltration, No calcifications in this lesion. Now, in a female age 40, if you find a solid lesion in this part of the pancreas, there are very few lesions that do that. And in an asymptomatic individual, you have to consider that this is most likely going to be a solid pseudopapillary tumor. Now, there are typical features and atypical features for this tumor. Let's have a look at some of the differences between typical and atypical. This was a solid pseudopapillary tumor of the pancreas. It is an uncommon lesion, but this is the commonest location for it. It can occur, most of the lesions are seen in the distal body and tail of the pancreas. It is recognized as a locally with a low-grade malignant potential. So these tumors have to be removed. The typical feature is female predominance, seen in the tail of pancreas with a pseudocapsule calcifications. They can occasionally have small areas of hemorrhage or hemorrhagic products within the lesion. And so there may be high signal on T1 in MRI, or they could be, if they're chronic hemorrhagic products, can be low signal on T1 and T2. They can have a peripheral to homogeneous enhancement. No ductal dilatation is seen. There is no invasion of the surrounding structures in the typical type of solid pseudopapillary tumors. And as I said, they can have a high signal on MRI. The atypical features are exactly the opposite of the typical features. It can be seen in male or in a pediatric population. They can be seen also in head and body with no calcifications, entirely solid, or they could be entirely cystic. The calcifications can be nodular and popcorn type calcifications, or they can be sheet-like calcifications along the periphery of the lesion. No hemorrhage, they can have no enhancement. Occasionally, they can be large enough to cause extrinsic compression and cause ductal obstruction with dilatation. There are some of the locally aggressive lesions which can cause local invasion into spleen and into retroperitoneal fat, and it becomes difficult to distinguish them from pancreatic adenocarcinoma. And most of these lesions have a pre-surgical biopsy with endoscopic ultrasound. They can also have low signal on T1 weighted MRI study. Moving on to the next case, this is a 57-year-old male patient presented with pain radiating to the back and change in bowel habit. The patient had a plain X-ray of the abdomen. It was reported as unremarkable, although you can give yourself a gold medal if you can pick up that there is a ill-defined soft tissue opacity here, which is indenting on the gastric saddle. In retrospect, this was seen as a well-defined opacity suggestive of a mass lesion. The patient then had an ultrasound scan by then, which showed a large hypoechoic mass lesion with areas of solid and cystic spaces, again arising at the distal body and tail of pancreas. On ultrasound of the liver, you can see that there are focal lesions clearly suggestive of metastatic disease. The patient then went on to have a CT and MRI. Isodens on pre-contrast CT shows a well-defined lobulated soft tissue mass, the distal body and tail of pancreas. Pretty much all of my cases are going to be in the same location, not just pancreatic lesions, but in the same location. So you can see a spectrum of these lesions in that location. Arterial phase images show a diffuse enhancement of the gland with heterogeneous solid component within the lesion. Now you can see that this is a solid mass which has undergone cystic degeneration. I say that because you can see that the mass has a hourglass shaped, or it has taken the shape of a lobulation where there was a pre-existing solid component which has undergone degeneration. Usually primary cystic neoplasms have a rounded appearance. They are primary cyst, they have smooth, well-formed rounded cysts as a cystic neoplasm. So you have to observe the appearance of the lobulation to know that this is a cystic degeneration in a solid tumor. You can see that the vessels are discontinuous and appear encased here within the pancreatic gland. So this is a locally aggressive type of lesion with peripancreatic infiltration. Diffusion-weighted images of the upper abdomen clearly show metastatic deposits in the liver, which were also picked up on ultrasound. And the larger part of the solid component of the mass shows diffusion restriction with heterogeneous breakdown of the tumor tissue. So what could this lesion be? I think the appearances are largely non-specific, but one could say for a lesion to occur to this size, this could not be clearly an adenocarcinoma. It's got to be a non-functioning tumor of some sort, which is grown exophytic to the pancreatic gland without causing pancreatic ductal obstruction. And by time that this has grown into a large lesion, it has already caused liver metastasis. As I said, these are the lesions that we need to be careful about, and we should be more aggressive in our approach to identify. Unfortunately, this patient had a few CT scans before this presentation, and the lesion was seen on one of the scans, but was missed. This is a patient and had a biopsy. This was confirmed to be a poorly differentiated pancreatic neuroendocrine carcinoma of a large cell type. PET study confirmed increased avidity within the lesion with multiple liver lesions. 6 weeks post chemotherapy, you can see that there is marked reduction in size of the tumor, solid component of the tumor. However, there is still some residual disease seen at 11 months. This was histologically reported as a grade 3 poorly differentiated tumor composed of monotonous cells with medium to large sized round nuclei and prominent nuclei. This is a copy from his previous CT study, which was done in May 2019. You can see that the pancreas was normal in appearance at the time. But however, in May 2020, when he had a CT scan for some non-specific symptoms of constipation, there was a definitive focal lesion seen in the distal body and tail of the pancreas, which was not picked up, and subsequently within 5 months showed that the lesion had grown significantly in size with multiple focal metastatic lesions in the liver. This rendered the lesion inoperable, so the patient could not have surgery and went on for chemotherapy and immunotherapy. A recent publication by some of our peers and our colleagues from our ex-NIMS alumni published a paper with a update on pancreatic neuroendocrine neoplasm, which is a very interesting read, and I was very happy to read this article coming from some of our colleagues. The pancreatic neuroendocrine neoplasms are histologically classified into 2 types as well-differentiated pancreatic neuroendocrine tumors, and were classified as poorly differentiated pancreatic neuroendocrine carcinomas. So the PAN-NETs and the PAN-NECs are the 2 groups which were described in the 2010 WHO classification. However, recently, they have identified a new tumor subtype, which is the well-differentiated high-grade pancreatic neuroendocrine tumor, which has been included in the classification. The high-grade pancreatic neuroendocrine tumors and pancreatic neuroendocrine carcinomas are 2 distinct entities with different pathogenesis, clinical features, and imaging findings with treatment options and different prognosis. Moving on to our next patient. This is a 55-year-old male patient who came with a history of worsening neck pain, had an MRI of cervical spine. Obviously, he's got disc degeneration with a bulging disc herniation, indenting on the ventral surface of the thecal sac at C5, C6, and C6, C7, The larger part of the interesting feature here is that he has multifocal bone marrow lesions, non-contiguous vertebral involvement, also involving the posterior elements of the vertebral bodies. The study was extended to the dorsal spine, which shows multiple focal lesions in the dorsal spine, and also lesions were identified in the lumbosacral spine, involving almost all of the skeleton. While axial images were being obtained for the dorsal spine, the technologists also noticed that there were multiple focal lesions within the liver. So, not knowing whether a primary malignancy was in this patient was then completely evaluated with CT and MRI. Patient had no joint disease, fever, infection, or metabolic bone disease, fit and well, except that he had lost weight recently. Went on to have a CT scan. On the CT, you can see that there are some small focal areas of low attenuation that you can see in the arterial phase, not really enhancing brightly in the arterial phase. However, in the later phase and the portovenous phase, you can see that there are multiple metastatic lesions in the liver. The pancreas is absolutely normal. You can see a well-defined pancreatic duct, pancreatic gland enhances normally. There is no evidence of a pancreatic neoplasm. So where is the primary? In patients who have an unknown primary and present with liver metastasis, the commonest cause for these are adenocarcinomas. They can be from adenocarcinomas from the gut, they could be from squamous cell carcinomas, or they could be from melanomas. So these are the commonest lesions that we try and identify. So looking for them, the patient went on to have an MRI of the liver on T1 weighted images. You can see it's very much iso-intense. None of the focal lesions in the liver is demonstrated on T1 weighted images. Out of phase image showed no abnormality. However, on T2 weighted images, you can see that the liver is fully studded with multiple lesions of variable sizes, and there was no evidence of a primary lesion that could be identified to explain the metastatic disease. Liver biopsy was performed. Histology revealed high-grade neuroendocrine carcinoma of small cell type. So where exactly is the lesion? It could not be identified on post-contrast enhanced images. Post-contrast gadolinium enhanced images show hypervascular metastasis with a peripheral rim of low attenuation, low signal, gradually increasing in signal into the later phases. No specific finding to tell us what kind of metastasis this could be. However, there is evidence in literature to look at multi-phase CT enhancement characteristics of metastases and try and identify where the primary could be in case of neuroendocrine carcinomas. Neuroendocrine tumors can arise from pancreas, they can arise from the gut, whether they're called gastroenteric neuroendocrine tumors, or they can arise from lungs. Patient underwent a CT PET study. On the CT PET study, there was a focal area of increased uptake seen at the cardia of the stomach. You can see that there is a focal avid area. The patient underwent an endoscopic procedure to find this nodule in the fundus of the stomach, which was biopsied and confirmed to be neuroendocrine tumor. These are sagittal images showing multifocal disease and metastatic disease into the bones, and axial images confirming that there was no pancreatic lesion identified. In patients who present with metastatic carcinoma from unknown primary, neuroendocrine tumors can be a cause in 11 to 14%. So this is the study by Basak and Gulpina, which showed if patients underwent multiphasic CT who had neuroendocrine tumor metastases, The primary could be in the pancreatic origin if they showed hyperdense arterial phase lesions and isodense on portal and hepatic venous phase. If the primary tumor was a gastroenteric cause, the liver metastases had a hyperdense feature in the arterial phase and hyperdense in the portal venous phase, as seen in our patient. Most frequent pattern for lung neuroendocrine tumors were hyperattenuation in all three phases of contrast. So in approximately 50% of patients with gastroneuroendocrine tumors and lung metastases have a specific pattern of enhancement that you could attribute and identify the primary site, whereas the pancreatic neuroendocrine tumors, up to 80%, have a specific pattern of liver metastasis. Okay, moving on to some of the cystic lesions of the pancreas. Case number 5. This patient presented with deep jaundice, no pancreatic pain or fever, no evidence of acute pancreatitis. Previously was treated for multiple myeloma. An ultrasound of the upper abdomen was performed, showed normal gallbladder, no gallstones. He had significant intrahepatic biliary ductal dilatation. Common bile duct was dilated. The pancreas could not be clearly identified. There was a large area of cystic degeneration or a multicystic appearance in the pancreatic bed. ERCP was planned to relieve the common biliary ductal obstruction, and at endoscopy during the ERCP, the endoscopist found a large lobulated mass eroding into the posterior wall of the stomach and almost encroaching into the duodenum and obstructing the duodenum. He could not get past into the duodenum, and he failed to identify the ampulla or cannulated. Endoscopic ultrasound showed large multicystic pockets of fluid and debris in the pancreatic bed. Ultrasound-guided aspirations were performed, and a biopsy was also taken from the lesion. The Center for Fluid Analysis and Histology was inconclusive. However, there was some doubt as to an increased amount of IgG within the cells on cytology. Molecular markers were not checked. The patient was deeply jaundiced and no other symptoms. MRCP was performed, which shows a markedly dilated common bile duct, intrahepatic biliary ductal dilatation, and also shows significant smooth dilatation of the pancreatic duct. The pancreatic duct was dilated all along the length of the gland, and in the tail region completely disappeared into a large cavity. So the morphology of the pancreas is completely lost here. You cannot identify the pancreas. See that there are large lakes of fluid with obstruction. So what are the possibilities here? You see on T1 weighted images, there is no evidence of hemorrhage, there's no obvious fat. T2 weighted images showing a pancreatic duct dilatation along the center of the gland. Following administration of intravenous contrast, we see the margins of the fluid cavities are enhancing, really giving us no clue as to what we are dealing with. Could this be all of these possibilities? The possibilities we considered, I will come to that in a minute. So on the pancreatic mass, you can see that there is tapering of the CBD. Again, large cavity, retrogastric eroding into the stomach, which was seen on endoscopy. You can also see some of the branch ducts in the uncinate process are dilated. So we wondered, was there a primary adenocarcinoma here, which had caused duct dilatation and rupture of the gland? But you can see that the pancreatic duct is smooth in appearance within the head of the pancreas. So where is the mass? So we proceeded to do a CT-guided biopsy of the lesion. Quickly, a review on the diffusion weighted images shows moderate diffusion, and this is the appearance on ADC. So we were wondering, what is this lesion? Is it a pancreatic plasmacytoma? This patient was treated for a multiple myeloma, and a small group of patients can present with extramedullary plasmacytoma in patients with multiple myeloma. Or is this a pancreatic lymphoma? It does fit in with the age, but the appearance of a pancreatic lymphoma is usually a diffuse, homogeneous enlargement of the gland with peripancreatic infiltration occasionally, but we have never seen a pancreatic duct rupture or causing complete obstruction to the biliary system. Although with significant edema in the head of the pancreas, you can get biliary ductal obstruction. Or is this an intraductal papillary mucinous tumor? Because on the aspirates, mucin was obtained when endoscopic ultrasound aspirations were performed. Or is this autoimmune pancreatitis with IgG4? Or is this a pancreatic adenocarcinoma? So I then proceeded to perform a CT-guided biopsy. The patient had mild renal insufficiency. Being a multiple myeloma patient, we did not want to give him intravenous contrast, and I had to plan the biopsy based on a non-contrast study. You can see that the pancreatic duct in the center of the lesion is diffusely dilated. There is almost no pancreatic solid tissue around this, diffusely atrophic. The end of the duct looks like it's ruptured with peripancreatic fluid. The only remnant solid component is seen in the head of the pancreas. So I took a plunge into it through a transgastric approach and got some specimens for histology. This was the histological report for the patient. The associated stroma within the patient showed dense lymphoplasmacytic infiltrate with storiform fibrosis and microvascular proliferation, or you can have venous phlebitis within the lesion. These three features are the hallmark of IgG4. If you see lymphoplasmacytic infiltration, storiform fibrosis, and microvascular proliferation, you can be almost certain that this is IgG4 type of autoimmune pancreatitis. The patient was also positive for, and also looking at the morphology of the lesion, the patient has a Ki-67 labeling index approaching up to 30 to 40%, which is suspicious again in a diffuse type of IPMN, which is a main duct IPMN. So we are still not confirmatory on this case. We suspect that this patient has dual pathology with intraductal papillary neoplasm and autoimmune pancreatitis. The patient was put on steroids, and very quickly the edema within the head of the pancreas resolved and the bilirubin reduced, relieving his jaundice. He has not had any intervention for a biliary procedure yet. So cystic lesions, or a ill-defined cystic component lesions around the pancreas, can be quite tricky. For the radiologist mainly, you need to be aware of specifically 5 types of cystic lesions. Pancreatic cysts are common. Now with the increasing number of CT and MRI that we do, we expect to see pancreatic cysts in about 3 to 14% of patients undergoing routine imaging. This is done, this is a prevalence seen in one of the largest studies done for screening MRI studies by Adjunct et al. Although mucinous cystic neoplasms represent a pre-malignant condition, it is now known that the majority of these lesions do not progress to cancer. So there have been new guidelines regarding the surveillance of these cystic lesions of the pancreas. Quickly, let us look at what an approach we can take when we see when we see cystic lesions of the pancreas. When you come across a pancreatic cyst, they are going to lie, the large majority of the lesions are going to be within these 5 components. The benign cyst is usually a pseudocyst. The large majority will be a pseudocyst, and you never get a pseudocyst without the patient having an acute pancreatitis. So you're almost there to make a diagnosis with accuracy if you have history of acute pancreatitis. Serous cysts or benign cysts, they almost never become malignant. They're benign in nature. Then even looking at a very large series of 2,500 patients, the incidence of a serous cyst adenoma becoming malignant, serous cyst becoming malignant, is 0.1%. So the chance is so small that you can almost ignore it and consider it as benign lesion requiring no surveillance. On the other end of the spectrum, you have a cyst which occurs within a pancreatic carcinoma or a neuroendocrine tumor. This is clearly malignant, will contain solid components, and it is not difficult to distinguish solid components within a cystic lesion on endoscopic ultrasound. So you can clearly categorize this patient into a malignant lesion. And if the features of the lesion are suitable for resection, they will go for surgery, and it needs to be managed in a multidisciplinary team at a tertiary referral hospital. It is these two lesions which are the tricky cystic lesions of the pancreas, which are borderline malignant lesions. Some of them will need surveillance, some will go for surgery. Now let us look at the morphology and features on imaging that you need to look for. And sorry, is there some problem with the time? Am I okay for time?
Go ahead, Mahesh. No worries.
I'm okay. Sorry. With the borderline lesions, some of them will require surveillance and some will need surgery. So what can the radiologist do to improve his accuracy in making a diagnosis of these two lesions? I would say try to get as much information as you can from the clinician and also from the laboratory parameters. Did the patient have acute pancreatitis? This is almost critical for any pancreatic cystic lesion. If you have an answer to this, then you know that you're dealing with a pseudocyst and you can clearly dismiss all other possibilities. Does ultrasound show solid component? If there is solid component within the cystic lesion, it is going to be a high-grade dysplasia or cancer, and you know clearly to put this in the malignant box. Does the pancreatic duct communicate with the cyst? If it communicates with the cyst, this is going to be either a pseudocyst or IPM. These are the two main cystic lesions which communicate with the pancreatic duct. With the mucinous cystic neoplasm and the serous cyst, they do not communicate with the main pancreatic duct. So it is important for you to get all this information before you can actually do your report. Try to obtain cyst fluid analysis information. If the cyst fluid CA is low, less than 5 nanograms per ml, it is most likely to be a pseudocyst or a serous cyst. If the cyst fluid CA is high, more than 190 nanograms per ml, they are more likely to represent IPMN or MCN. The aspirate is also mucinous in nature, so that gives a clue that we're dealing with IPMN or MCN. Now, cytology can be inadequate in a large number of patients, so we do not have to depend much on the cytology obtained by endoscopic ultrasound, although if you see malignant cells, then you clearly know where to put them in your list of surveillance or surgery. What are the molecular markers you should look for? If you see GNAS mutation, almost exclusively, these are seen in IPMNs. Although IPMNs all the GNAS mutation can occur in other diseases of the abdomen, including hepatocellular carcinoma, adenocarcinomas. But if you see in a cystic neoplasm of the pancreas with any specific type of IPMN characteristic, where you have pancreatic ductal dilatation, the main pancreatic duct is dilated, or the branch ducts are dilated, or you have a combination of the main duct and the branch duct being dilated. These are suspicious features for IPMN. The reason this is important is about 40% of IPMNs have a risk of developing invasive carcinoma. So they should be triaged properly to get the appropriate treatment. If you see a KRAS mutation, they can be seen in IPMN, as well as they can be seen in mucinous cystic neoplasm. If you see a VHL mutation with absence of GNAS or KRAS mutation, they are highly specific for serous cysts. So you can discharge the patient requiring no surveillance. Let's look at some of the examples. This is another patient who presented with a lesion exactly at the same location that I have been talking about, at the distal body and tail of pancreas. Very well defined low attenuation on post-contrast and CT. This is an ultrasound image, shows the cystic appearance of the lesion. Doppler evaluation shows that there is not very much increased vascularity around the lesion. Within the substance of the lesion, there are some solid components with fluid. This was a 28-year-old female with one episode of pain in the upper abdomen. Was diagnosed to have a cystic lesion in some other facility. MRI and endoscopic ultrasound diagnosed it as mucinous cystic neoplasm. Endoscopic ultrasound fluid showed carcinoma antigen of only 2 nanograms. So this does not really fit into, this could have been dismissed as a serous cyst, but the morphological features do not fit into serous cyst. Serous cysts are usually multiple small locular cysts, where there are cysts within a large cyst. Usually more than 6 microcysts within a large cyst is required to make a diagnosis of serous cystadenoma. CA99 was 381. Patient then went on to have endoscopic biopsy and was confirmed to have a mucinous cystic neoplasm. Because the lesion showed a high-grade ATPM, patient then went on to have a distal pancreatectomy. So you can see here that the pancreas is resected, including a splenectomy was done for this patient. This is another example of a large cystic neoplasm, of mucinous cystic neoplasm. They almost always occur in the distal body and tail of pancreas. Female predominance, you can see that there are multiple septae within the lesions. This is a non-contrast enhanced CT, which shows that there is a homogeneous appearance of increased density here, suggesting that there is probably some bleeding within the cyst. Focal areas of calcification seen in the septae. These are typical for mucinous cystic neoplasm. Following administration of contrast, you see there is almost no enhancement of within the lesion, except that the septae are enhanced. On MRI, low signal on T1, homogeneously high signal on T2 with internal septae, classical of mucinous cystic neoplasm. This is a 60-year-old female, incidental lesion seen in the distal body and tail of pancreas again. This is the typical appearance of a serous cyst. You can see the multilocular appearance of the lesion. It is a small sized lesion with a central scar. Usually there can be focal areas of calcification. Following administration of intravenous contrast, there is no enhancement within the lesion except for minimal marginal enhancement. The serous cysts can occur anywhere within the pancreas. They can occur in the head, body, tail, and they don't have a predilection for site. The multilocular T2 high signal, no CE on cyst aspirate. Occasionally you can find VHL gene mutation. They have no malignant potential, except reported in a 0.1% potential for malignancy. Now let us move on to some other interesting cases in the abdomen. This is a 40-year-old male patient. I just put it up as a first image, but this was not the first image done for the patient. What do you think is going on here? Just looking at this one image, if you can tell me what is going on with the patient. He has a high avid lesion in the caudate lobe. Obviously, this is a metastatic lesion. Why do I say that? Because I have the clue here saying that the left kidney is missing. He had a left renal cell carcinoma with a nephrectomy. And this is a metastatic deposit in the caudate lobe. The patient then went on to have an MRI scan. The MRI scan is somewhat deceivingly looks like a focal nodular hyperplasia. Let's look at the features here. On pre-contrast images, it is not iso-intense with the rest of the liver. It is hypo-intense. And on T2, somewhat higher in signal than the rest of the liver. Central area of high signal, significant diffusion restriction. Following administration of gadolinium contrast shows a peripheral enhancement in the lesion. Gradually begins to enhance within the central portion of the gland. This is not to be mistaken for a hemangioma, but from peripheral to central enhancement. If you remember, the previous lecture by Vamsi was very interesting, where he said, if you see washout in the periphery of the lesion, much lower than the rest of the liver, you should suspect malignant disease. So this was a patient with malignant disease. There's a metastasis from the renal cell carcinoma that he had. The patient went on to have a metastectomy from segment 1, including the left lobe of the liver was removed. You will also remember that he mentioned about these focal clips. If you are doing a caudate lobe resection, you would see susceptibility artifacts. And the only other condition that you can find this would be if the patient is going to have a renal transplant. Sorry, a liver transplant. Next patient. Sorry, it is not projecting the history here. I don't know if you can see the history. Anyway, patient presented with abdominal pain, vomiting, multiple lobulated soft tissue lesions seen arising from the jejunum. What is the diagnosis, or what are the possibilities? Is it adenocarcinoma of small bowel? Yes, it could be. I don't think there is any way to say no to that. But you can see that there is also aneurysmal dilatation of the bowel. Is this a lymphoma? Could be. Or is this gastrointestinal stromal tumor? I don't see any obvious ulceration or extension in the lesion, but however, you can see that there is some air getting into the central portion of this lesion. So it could be a gastrointestinal stromal tumor, or is it a submucosal neuroendocrine tumor? So all of these are possible. Or is it none of these? It was none of these. It was a multifocal extrarenal rhabdoid tumor. These MER tumors of the jejunum are extremely aggressive tumors. The rhabdoid tumors are extremely aggressive when they are seen in the gastrointestinal tract. They are multifocal in lesion, multifocal in the small bowel. They rapidly progress. They can bleed. However, this patient, because he had obstruction to the bowel, the surgeon went in to resect those segments. And post-resection, patient continued to have bleeding around the anastomotic site. You can see large perianastomotic hematomas. Patient continued to deteriorate and rapidly deteriorated with multiple areas of bleeding in the small bowel. So this is a very uncommon condition. Small bowel tumors itself are not very common. Small bowel tumors the small bowel accounts for 90% of the gastrointestinal surface area. But tumors of the small bowel are rare. It's only about 0.5% and 3% of all gastrointestinal cancers. Frequency of small bowel tumors should be remembered decreases from proximal to distal small bowel. The duodenum and the frequency in the jejunum, with frequency greater in the jejunum than in the ileum. Rhabdoid tumors of the small bowel was first described from Wim's tumor in 1978. Malignant rhabdoid tumors were described in Wim's tumor. The extrarenal locations were typically described in the central nervous system. and also in liver, soft tissue, and colon. Aggressive lesions having poor prognosis. Malignant rhabdoid tumors of small intestine is very rare. Only 7 cases have been published until 2008. I don't know, we may be publishing this one. Let's see. Third spotter, I don't want to call this a spotter, it's very unfair to call this a spotter. 65-year-old female, severe abdominal pain, no jaundice. I think for Nizam postgraduates, this could be a spotter. So what we're seeing here, this is a coronal CT study obtained with intravenous contrast, no biliary ductal dilatation, good opacification of the portal vein, stomach, duodenum, and there is a space-occupying lesion seen here at the uncinate process. Very bright, almost iso-intense with the rest of the bowel. Central area of low density, has a kind of a concentric laminated appearance. On the axial view, has a peripheral rim of low signal. It looks like some part of the bowel has gone into another segment of bowel, which you would see with a concentric ring appearance of bowel and intussusception. Or is this a tumor? Or is this, what are the possibilities here? It's not very dense to be a calculus. You can see a soft appearance of this lesion localized within the retroperitoneum. So it is actually in the retroperitoneum, in the immediately adjacent to the uncinate process. Seeing some fluid here coming from the gallbladder. I don't know if anybody wants to take any chances. Am I seeing anything in the chat box? Any guesses? Oh, yes, I missed seeing these messages. Somebody had taken a guess on the previous one. Adenocarcinoma of the colon. Ectopic gastric lesion. What do you mean by that? You mean ectopic gastric mucosa? Unusual location for ectopic gastric mucosa. Although you can see it within the bowel, this is actually extra luminal to the duodenum and the small intestine. It is in relation to the uncinate process of the pancreas. Okay. MRI was performed. Just turn the chat box off. MRI showed very low signal lesion, peripheral high signal. Patient went on to have surgery. This was found to be a perforated enterolit from the duodenum lying in the uncinate process, uncinate space. I don't really want to call this a Bourette syndrome, where you would see actually the stone coming from the gallbladder. The patient did have a small amount of fluid, and it was not clear whether there was no evidence of a fistula found from the gallbladder into the duodenum. So this must have been formed in the gut and extruded out of the bowel into the uncinate process. It could have occurred from the second part of the duodenum, but there was no diverticulum seen in the second part of the duodenum at surgery. So that was a mystery case of enterolit perforation into the retroperitoneum. Patient had surgery and then developed a biliary fistula, which was chronic biliary leak, which required continual drainage and then was managed successfully. Moving on to the next case. This is a spotter. I'd like to thank my colleague, Dr. Samad Punekar, for giving me this case. Ultrasound of liver shows multiple focal low-density lesions. So if you are doing ultrasound, what could this be? This could be metastasis. There is some degree of fatty change you can see in the liver, with sharp contrast to the kidneys. Doppler evaluation shows no increased vascularity. Could be anything else. Could be fungal disease. I don't know. So we went on to do a CT scan. On CT, we couldn't find anything. In the arterial phase, you can see that there is an homogeneous appearance to the liver. So then the patient was curious to know what these lesions were, and then went on to have an MRI scan. In the MRI scan, you can see that there were some focal areas of high signal. Sorry, this is the post-contrast CT in the delayed phase. You see that there were some focal areas of enhancement on CT. And then the patient went on to have an MRI scan. So any guesses what these are? Could this be metastases from breast? Could this be arterial phase enhancing vascular metastases? Obviously, we're not seeing anything. There is a background of fatty change in the liver. The patient went on to have an MRI, wanted to be sure with all the sequences that we were not missing something. On T1 in phase, where fat is in phase, the rest of the structures, don't see anything on the in phase. In the out of phase images, you can see there are some focal areas of higher signal. So obviously this is not fat. You would not expect them to be low signal. You're not seeing anything on CT. It's enhancing the contrast. And they are not seen on the out of phase images. They're showing when gadolinium was given with intravenous contrast, you can see that there is some enhancement of these focal lesions. Although these are largely vascular markings. Fat suppressed T1 post-contrast enhanced images definitely shows that there are focal lesions in the liver. So what are these? In the background of fat suppression in a fatty liver, you are seeing enhancing rounded lesions. Any guesses? Don't see a chat box. I'm not able to read their chat box. If you can read it out, somebody, any guesses?
Multiple adenomata. Okay.
Yes, that is one possibility. Good idea. Adenomatosis can look like that, but the patient has multiple adenomatosis is a good differential diagnosis, but there is no diffusion restriction. Adenomatosis usually is not seen in patients. I just wanted to make a mention about adenomatosis, is that it is not the same as a hepatic adenoma. Adenomatosis is slightly different from adenomatosis. In adenomatosis, you would see the lesions would have central area of fattening. So hepatic adenomatosis will have steatosis within the lesion. You're not seeing any fat within the lesion on these cases. And it is enhancing with contrast. And we don't see a sustained enhancement with the lesion. Anything else you can think of? Could it be infective foci?
Can I talk, Mahesh?
Yeah, sure, you can.
In the T1 fat sat images,
Yes.
Especially opposite phase,
Yes.
when your background is very dark because of fat, focal fat sparing will be hyperintense.
Correct.
Due to relatively dark background.
Correct.
So can I have a look at that, please, if you have that?
That is what this is.
Okay.
So because of the fat being low signal in the out of phase image, you see that this fat is suppressed. And in contrast to that, you're seeing this is normal hepatic parenchyma, which is enhancing the background of fat suppression. So that is why it looks like focal areas of metastasis. You see on diffusion weighted, we do not see any I don't have the diffusion weighted image, I think here. Let me just go back. I don't have the diffusion weighted images, but we did not see any restriction, nor do we see any enhancement here. So these are not hepatic adenomata. These are simply normal liver tissue enhancing in the background of fat. So the focal fat spill. Very good. So then moving on to the next case. This is a very straightforward case. I put this as almost the last case, I think. 50-year-old female came with right upper quadrant pain, no other symptoms. On T1 weighted shows a homogeneous low signal lesion in the liver. And on T2 shows a stellate shaped central area with peripheral high signal. On post-contrast enhanced images shows central area of necrosis and gradually filling in of the lesion. And you can almost see there is a small area of peripheral capsular retraction in this lesion. Anybody wants to take a shot at this?
It appears like cholangiocarcinoma, but
yes,
appears
very
like
good.
Can you show me ADC also?
I don't have the ADC image here on my slides. I'm sorry, but it is a cholangiocarcinoma. They're absolutely right. If you see a mass which is homogeneously low signal on T1, very homogeneous, and with capsular retraction, the stellate type of appearance, and this and that, it is almost always a cholangiocarcinoma. We've had a series of these, so it was not difficult to pick this up. Patient then went on to have a hepatic resection and also had a right nephrectomy. Do you know why? Because on this image you can see the patient also had a right renal cell carcinoma. So that is all I have for you all today. Thank you very much for your patient listening. If there are any questions, please direct them to Vijay Bhaskar.
Mahesh, I have a doubt for you.
Yeah, sure.
In that case of IPMN,
Yes.
now, if we don't have a biopsy diagnosis,
Yes.
other than IPMN is a straightforward diagnosis. The MR picture is very, very typical of, like you described, fantastic description textbook wise. Everything is perfect description. Lakes of mucin, everything you described. But can you suspect background IgG on imaging, and how?
No, I have not been able to. The vast majority of IgG pancreatitis is a kind of, because it's in a kind of autoimmune pancreatitis, you'd see a diffuse solid appearance to the lesion. You would not see a breakdown. Necrosis is uncommon in IgG. So you should not see necrosis. You should not see infiltrates from polymorphonuclear cells. You should see specifically, you can see plasma cells. This patient also had multiple myeloma. You can see plasma cells. So if you have lymphoplasmacytic infiltration, that is very typical for IgG on histology. Whereas on imaging, you don't see necrotic tissue. And at some stage, we wondered whether the patient had pancreatitis because of the areas of loculations that we were seeing around the pancreatic bed with the dilatation. We wondered whether he had a pancreatitis which had ruptured the pancreatic duct and caused these leaks, but IPMN could do that.
How do you explain this distal CVD stricture? Is it because of compression?
We thought it was because of edema, because there is so much of edema in peripancreatic inflammatory sort of response or a mass effect, because the lesion was almost eroding into the second part of duodenum. So it is all of that edema within the remnant head of pancreas, which had caused if you see the lesion, it doesn't look like a growth within the common bile duct. It looks like a stenosing tapering, like a pencil tip appearance of the distal CVD.
Okay.
So you can get that with focal acute pancreatitis as well, which we also describe on MRCP in the pancreatic duct when you see it as like a duct penetrating sign if you see on the pancreatic duct side. This is seen in the distal CVD.